So this lecture is on emergency cardiac sonography. Main use is for the bedside point of care in the emergency room, emergency department, or the intensive care units. So remember, just like any other ultrasound procedure bedside we have to have focused questions. Remember, we're not doing full cardiac echocardiograms. This is just a bedside procedure to help us make a decision on that will make an immediate impact on the patient. So the focus questions that we have is, what is the lung profile? And we're going to talk about a little bit of that, but remember there's a whole lung module and advanced lung module that you can go through. Is there pericardial fluid and tamponade physiology present, which is also discussed in another lecture? Left and right ventricular function is poor, normal, or hyperdynamic. Each one of those has another lecture also. IVC variation in size, and there's another lecture for that also. And then remember, the probe you use is going to be the low frequency phase array or cardiac probe. So why do we want to look at the heart? Why does the intensivist want, or critical care physician want to look at the heart? Remember, pulmonary edema is a lung diagnosis, but it must be integrated. You must integrate lung in the emergent evaluation of the heart. There are many protocols that have come out over the last years: RACE, FEAR, FATE, FOCUS. They're all point of care cardiac ultrasound used in various different specialties, but mainly critical care. And all of them have some component of the lung ultrasound in its algorithm. Remember, also, measurements are rarely made. This is a visual medicine, but can use M-mode for documentation purposes. The roots of the heart roots that we can use are parasternal, apical, subcostal, or subxiphoid. Knowing all the views are important in critical care because every patient is dependent as to which is optimal. Sometimes, for instance, in COPD patients, subcostal or subxiphoid views are the best. Sometimes in obese patients or patients with abdominal surgeries, parasternal views are great. Most of our patients were not able to get great apical views because having to put the patient in the left lateral decubitous position. Although if that's an option for you, that may be something that can help you get a good view. So I'm going to go through some basic views. Although this is covered in another lecture, I do want to just briefly go over the different views. So remember, parasternal view is parasternum. If the probe marker is pointed towards the right shoulder, that's the parasternal long view. And you cut the heart in long axis, and you're able to see the left atrium, left ventricle. Sometimes partially the right ventricle. You don't always get to see a great view of that. And a good parasternal long view is where you can see the mitral valve and the aortic valve in the same view. In this picture here, you can actually see that the mitral valve is right here, and the aortic valve is right here. The mitral and aortic valve actually have an attachment point, and if you can get that attachment point, that's pretty much the center of the parasternal long view. It is very important that you get a good parasternal long view because all the rest of your views are based off of having a good parasternal long view. So if it takes a little bit extra time getting that view, it's worth your time. So here's a motion image of the parasternal long view. So again, you see the right ventricle, the left ventricle, you see the mitral valve, the aortic valve, the aortic outflow tract, the left atrium, the left ventricle, the pericardium, which is a broad hyperechoic. You see the left lung, and sometimes you can see a left pleural effusion back here. And an important structure to identify for pericardial effusion evaluation is the descending aorta. It's very important you familiarize yourself with this so that when you have difficult patients, you have an idea of where things are, because they don't always look this nice. So parasternal short actually is if you rotate, after you get a great parasternal long, if you rotate your probe 90 degrees to the parasternal to the left shoulder, you're going to be in the parasternal short plane. Now the parasternal short actually has 5 different levels. This is a really great picture because it kind of shows you essentially the plane cuts that you're getting. So the first The first view that you normally get if you get a good parasternal long view and then move to here is you get a good mitral valve view, which would be around here somewhere. The views that are actually obtained once you find that view is you can fan your probe towards the patient's left hip and then fan it back all the way to the right shoulder. And essentially, if you fan it towards the left hip, if you go all the way where you lose your heart over here, the first view you get is apical. Then you get papillary muscle, which is what the view that you see here. These are papillary muscles. Then you get mitral valve. Then you get aortic valve. And then you get the pulmonary trunk. Each one of those are important for different disease processes, and we'll go through them as the course goes on. But it's important for you to be able to get these structures, and once you feel very comfortable with that, you'll be able to make decisions on patients a lot easier. So this is a parasternal short view. You see a short axis view of the LV, that's why it's called short axis. You see a right ventricle, and you see papillary muscles. Now, again, it's good to get a view of what's normal, because as we go through some more abnormal images, for instance, when I go through the left ventricle and the right ventricle lectures, I'll go through like abnormal images of these, and it's good for you to know what normal is. If you're trying to make a decision on function, it's best to make it in the LV short axis view at the papillary muscle level. You can be guaranteed that if you have a papillary muscle level, that you're right in the center of the LV. You can overestimate function at apical level and underestimate function at mitral valve level. That's why it's very important to be able to get at the correct level. This is the apical view. So after you get what I do is so the probe marker goes towards the right shoulder for parasternal long, then left shoulder for parasternal short, and then 3 o'clock position for apical. And some patients you can actually go just like right here and put it, but some patients you have to put in left lateral decubitus to get a better view. When you do that, you usually get a good 4-chamber view. Now this is one of the more difficult views to get, the apical, but once you get it, you can actually see the best relationship between the right ventricle and left ventricle. Also, because the blood flow is parallel to the probe in this position, you get the most accurate measurements. Although we don't make all the measurements for mitral valve regurg or tricuspid regurg, it is very important to know the fact that when your probe is parallel to the blood flow, that is the most accurate. So here's the apical view. You see a left ventricle, a right ventricle. Now, one of the most important things for us is a lot of times when we're trying to do this view, we're trying to determine the size of the right ventricle versus the left ventricle. And the basic thing that you have to have is if you're on the correct side or not. So one of the major ways to tell if the person has the correct orientation of the right ventricle and left ventricle is to look at the valves. The tricuspid valve always inserts closer to the ultrasound probe than the mitral valve insertion. So the ultrasound probe is up here, and you're seeing the right ventricle and left ventricle, and the reason why you know this is the right ventricle is because you have over here the tricuspid valve is inserted a little bit higher up than the mitral valve. Now sometimes this is difficult to see, but this is very important finding. And many times when you have patients that have complications like an elevated right ventricle, it may confuse you as to which side is which. This is a subcostal view of the heart. It's an abdomen preset. The reason why I like to show this is the reason why we see an abdomen preset frequently is because sometimes we're doing this as a part of a fast exam. One way you can tell this is subcostal is that you see liver over here. And if you can remember from your school, right ventricle is closest to the chest wall, so that's usually the right ventricle. You can still use the same technique of looking at where the tricuspid and mitral valve insert based on your ultrasound probe in this view. Even though this is not clear, sometimes in COPD patients, when you put your probe in the subcostal region, it actually looks like an apical view. So that's why it's important to know all the different views and conditions where you see the differences. So first thing I want to talk a little bit about is contractility and systolic function. You can put the M mode. The M mode can show left ventricular shortening fraction, which is normally 28 to 38% in the parasternal short axis view, or slightly below the mitral valve level, where you have the papillary muscles. Essentially is equal to the dimension in diastole minus the dimension in systolic divided by the diastolic dimension. Now remember, I told you we're not really quantifying any of this, so as I show you for more slides, what I want you to get good at is visually looking and determining whether the function is poor, normal, or hyperdynamic. Another caveat is diastolic dysfunction is very hard to detect. LV contractility is a field large in subtleties, preload and afterload status dependent, cardiac window position dependent, and operator experience dependent. So because of that, and even in our ICU, patients are on multiple pressors, inotropic agents that can affect the contractility. So what I want you to do is get really good at looking at general, and we're going to look at that. Also remember, you should always check the lung for profile, B profile, because if you have a B profile bilateral with lung sliding, that suggests pulmonary edema. And if you're trying to determine volume status or whether to give the patient fluids or vasopressors or inotropic agents, you have to look at the lungs to see if the heart is actually being able to keep up. The perfect example is sepsis. In patients in early sepsis, they're hyperdynamic and can tolerate large amounts of fluid. But shortly afterward, within 12 hours, 24 hours, typically the patient at some point becomes fluid overloaded. And at that point, the patient may benefit more from vasopressors or inotropic agents, depending on your ultrasound findings. So remember, what I want you to do is find the squeeze of the pump is to determine the global left ventricular function. The LV walls, you can do a visual calculation of percent change from diastole to systolic. And they said that in this study, which is a long time ago, but there's been multiple studies that have concluded the same, that radionuclide imaging and visual determination are roughly equivalent. And actually for us in the intensive care unit or in the critically ill patient, we don't even have to estimate the percent, because what's more important is whether you have good, normal, or hyperdynamic contractility. So first of all, for good and hyperdynamic contractility, the walls almost come together and almost obliterate the ventricular cavity during systolic. If you have poor contractility, the walls move little, and the heart may even be dilated. Remember, you're also looking in the LV. So even if the LV walls are having poor contractility, but you have low volume in the LV and no B lines on the lung exam, the patient may still be able to tolerate some fluid and may not need inotropic agents instantaneously. Another thing to look at is the anterior leaflet of the mitral valve, typically best done in the parasternal long view. In a normal state, it will be vigorously touching the septum during ventricular filling, and I'm going to show you some of that, as well as some poor images. So here you see a normal heart. You see systolic motion. You see the mitral valve in parasternal long almost hitting the LV wall, right where my arrow is. This is like normal function. This is the normal size of an LV. Remember, you can only make that comment if you can see the mitral valve and the aortic valve in the same plane. Here you see an opposite. This is a dilated left ventricle. This is a mitral valve, and you can see it's not even coming close to the LV wall. And remember, it has nothing to do with the mitral valve. It has to do with the left ventricular function. Now, you can have some mitral valve stenosis or mitral valve calcifications that may affect this, but what you're also looking at is the function, the volume in the LV. You can see that the left atrium is a lot larger than normal, as well as the left ventricle. And you can look at this in multiple different views. Here's a short axis view of a normal function. You can see we're at the papillary muscle level, which is important for you to find the papillary muscles before you make any determination. Here's the right ventricle and the left ventricle. And you can see as the contraction happens, you still have some remaining volume in the LV. So this is normal function. Here you see a patient that's not only tachycardic, but probably was in, if you have the right clinical scenario, like in hypovolemic or septic shock, either from hemorrhagic shock or from an infection. So again, you can see the right ventricle, the left ventricle. You can see the papillary muscles. And you can see total obliteration of the cavity every time the heart beats. So this would indicate, after you look at the lungs, if there's no fluid in the lungs, that the patient may need more volume. Here's a parasternal short axis of someone with poor heart function. You can see these are the papillary muscles. You can see the left ventricle. And you can see a large volume in the LV without any significant compression. Now we can look for segmental wall motion abnormalities. They're sometimes more difficult to identify, and in the ICU a lot of times we are not experts at this, but sometimes in the acute hypotensive setting it will help you identify a myocardial infarction. Here's a slide that shows the different segments of the heart when you're looking at it in different views. This is a apical four-chamber view. This is a parasternal short view. This is the mitral valve, a parasternal long view. So you can see the apex at the end and basal segment. The most common place that we look for segmental wall motion abnormalities, though, is the parasternal short axis view. So in this view, you can actually see there's a mnemonic called SALPI. And I'm going to show you a little bit of that on the, this is actually probably a TEE view. So it's opposite of what we normally see on a transthoracic. So here's a transthoracic view, short axis, just like we mentioned before. And you have a septum. You have a right ventricle, left ventricle, septum. And the mnemonic is SALPI. So this is septal. This is anterior. This is lateral. This is posterior. And this is inferior. You can even see a small pericardial effusion here. So you might ask yourself, can I do this? How can, when did I didn't really learn this too much. So there have been multiple studies that showed emergency physicians can estimate LV contractility. And a lot of this literature has been translated over to the intensive care unit. Identification of cardiogenic shock has led to earlier revascularization. Hyperdynamic evaluation in early sepsis has resulted in better fluid management. But I think the most important thing is the repeated evaluations you can do. If you order just an echocardiogram, you may get that done and you may get a read within a day. But then after you do your management plan, you're not able to reassess it quickly. Even if you order an official echocardiogram, you can do an echo at the bedside, make your management decisions that you may have made without your ultrasound, and then repeat your evaluation to see if the patient has benefited from your management plan, whether that was fluids, Lasix, pressors, or inotropic agents. I want to refer you to the pulmonary edema lecture, but a few slides at this time just to talk about pulmonary edema because it's such an important finding when you're evaluating the heart in an emergency or critical care setting. If you want more information on this, please go to the pulmonary edema lecture. So remember, B profile is bilateral anterior predominant B lines with lung sliding. So if you see pulmonary edema, almost no matter what the function is, the patient may not be able to tolerate more fluid. Either they have low nutrition status, or they actually have pulmonary edema from heart failure, and they may require more inotropic or vasopressor agents. Remember, B lines are evaluated in the anterior chest, and the more B lines you have, the more problems you have. I've managed many patients in the emergency department that come in with acute pulmonary edema, either from heart failure or from eating too much salt, and they come in the morning. I do the ultrasound and I see bilateral sliding B lines. We do our regular management with non-invasive ventilation, Lasix, and vasodilators like nitroglycerin, and usually within minutes you can actually see these disappear. They've actually done multiple studies also showing disappearance of these lines when patients are in pulmonary edema and are getting dialysis. So it's been proven pretty well that they're very accurate in identifying pulmonary edema. Here's an image of the B lines that you see. You can see that they're sliding. This is the lung. This is a rib with a shadow. And you can see the vertical lines. Again, this is showing A lines, which are horizontal lines, not suggestive of pulmonary edema. And here B lines that are vertical lines from the pleura that, if they are sliding, are suggestive of pulmonary edema, if they're bilateral. Remember, B lines can also be in other disease processes such as ARS, pneumonia, and pulmonary fibrosis, so you have to have the right clinical scenario in mind. So at the end of this, remember, emergency cardiac sonography has focused questions. What is the lung profile? Remember, we've discussed this elsewhere, and we have a whole module on pulmonary edema. Pericardial fluid and tamponade physiology present. Remember, this is also discussed in other lectures. The left and right ventricular function is poor, normal, or hyperdynamic. Remember, I have left ventricle and right ventricle are discussed in a little bit more detail during the respective lectures. And then IVC variation size. That's again discussed in reading and a short lecture to follow in another module. But these are the focus questions that you should ask yourself every time you do an emergent cardiac sonography. All right, thanks a lot.